kind of initiating this very, very special webinar on the day of eve of Women's International Day for Women, because this is really for the first time ever that we have an entire panel of women ortho spine surgeons. So a branch where firstly women were thought that they would never enter. Now you have expert and you have for young ladies all foraying into various aspects of spine. So totally heartwarming evening. And who better than Rushama Tandon, the pioneer in spine surgery in India for women, and Dr. Ram Chaddha, the IOA president and a spine surgeon par excellence and a leader of immense strength is what I think the word I would use for you today, Ram. And always supportive of voice. In fact, he has actually taken the step and given us our gold medal this year as well. So welcome Rushma, welcome Ram. And without further wasting any time, I will let Chasanal introduce all the young ladies today and take it away from there.
So thank you, ma'am, and welcome all to this wonderful webinar about enhancing women's bone health. And we have a very lovely fantastic four speakers. And to begin with, I'd like to call Dr. Taarini Johri. She's currently in a 2-year fellowship. It is an Association of Spine Surgeon of India, the ASSI Fellowship at PD Hinduja Hospital, Mahim, and under the mentorship of Dr. Samir Dalvi. So, Taarini, please share your screen and please start with your talk.
Yes, ma'am.
So we can see your screen. Yeah, it's clear. Nice. Great.
Okay. Good evening, ma'am and sir, and all my colleagues. Thank you for the introduction. So I will play a reverse Uno card, and I would rather introduce you three who and what you mean to us, because this Women's Day, you have been our constant motivator and inspiration as one of the few bold women in this field of orthopedics. So thank you for paving a way for all of us. It is because of your efforts for breaking that stereotype that we had a smooth transition through our residency. So this spine health is wealth is my topic, and we have been hearing that since ages now, that health is wealth. Yet you, the viewer, are watching this webinar all slouched in your chair, or are you even in the chair? Are you in the bed in the weirdest posture? Or are you on your phone with your neck in all complete flexion? Well, I can hear your spine screaming, so let's talk about that. Almost everyone will experience back pain at some point in their life. For maybe expect for maybe at this point in life. But so how did you go from this thumka to this thanka? Let's talk about that. For understanding your spine, you should know that the spinal cord is like the trunk of a tree, and the nerve roots act like its branches. Our body has a way of protecting the spinal column in a bony armor that is known as the vertebral column, and it has little keyhole like openings that you can see here that allow the nerve roots to exit. One spinal segment contains two vertebrae, a disc in between, and a nerve root exiting. Sometimes this disc tends to pop out and cause nerve root compressions and pains, but that is not the only reason. Anywhere throughout the column or throughout these structures, if there is something that is obstructing this complex highway of that is giving you pain signals, then there will be some sort of pain. So what are the type of back pains? There is acute, that is of a few days or few weeks. Then there is subacute, that is around 4 weeks to 12 weeks. And then there is chronic, that's been there for years. And there is another way of classifying it according to the nature. So there's something we call as mechanical, non-mechanical, and visceral. Mechanical include the picture that I showed you earlier. Anywhere in those things, if there is some injury or a deformity or more complex spinal problems, which will be covered in the further talks, then we would name them as mechanical. The non-mechanical causes include neoplasms, infection, inflammatory and metabolic causes like osteoporosis, and inflammatory causes like arthritis. So, and visceral include, and they're less talked about. Visceral are pelvic organ diseases like pelvic inflammatory diseases, or even ovarian cysts, or renal diseases like renal stones, abdominal aortic aneurysms, or even gastrointestinal diseases. So, what are the leading causes of back pain? It's poor body mechanics, stressful living and work habits, and general physical fitness decline. Poor posture. So, the signs of poor posture are that your shoulders are rounded, you have a pot belly, your knees are bent while standing or walking, your head either leans forward, that is, your ear is in front of your shoulders, or you have back and body pains. Even during pregnancy, as your the lower back pain during pregnancy is not uncommon, given that the physical changes that are taking place in the body and resulting strain placed on the joints of the lower back and the pelvis. The causes are multiple, which include the increasing size of the uterus, the relaxin hormone, which makes all your muscles and ligaments lax. There's a widening of the pelvis, the change in posture, and emotional stress and weight gain. Sciatica, every patient's almost favorite topic. It is a pain that radiates down from your back to your leg to foot, and well, there are ways to avoid it. Myofascial pain syndrome is also something that is less understood, so I wanted to elaborate on this. It is a syndrome that causes a chronic painful condition. It involves some muscles and a thin covering of tissue we call fascia that in this syndrome, there are areas of tight muscle fibers that form trigger points. And too much, this is the exact cause is not known exactly, but too much use of muscles, or more often with poor form or posture, or injury to the muscle, poor sleeping habits, or mental stress, anxiety, depression, likely are the reasons to cause these trigger points. So how does all of these things present as? Obviously, they have multiple ways, but if you have to generalize, you may have increasing pain while lifting or bending forward, worsening of pain while resting, sitting, or even standing, back pain that comes and goes, stiffness in the morning when you're waking up and then that lessens throughout the day as you're doing some activity, a pain that radiates away from the back to the buttocks or legs, or it may even cause you numbness or weakness in your legs. There's something I would want to emphasize on is red flag signs, that if you ever have back pain, but along with that you feel like certain things have developed in you, like there is a difficulty in passing urine, or there is some retention, there is less sensations in anywhere in your body, especially in the areas of your genitals as well as the inner aspects of your thigh, we call these red flag signs, and it means that your back pain has now become a bit more serious than usual and you should visit your doctor. Also, there are additional red flags for children, since it is Women's Day special. So even in your child, if the age is less than 4 years and the pain interferes with the child's daily activity, if there is a limp or an altered gait, or the back pain despite no clear mechanism of injury, or has repetitive or acute trauma, you must visit the doctor. So let's talk about spine health. How do we take care of our back? So we need to take care of body mechanics, proper lifting techniques, maintain safe postures, keep physically fit, stretch and exercise, stress management, good nutrition, hydration, adequate sun exposure, and to avoid smoking. So here it is. It is not that you cannot bend forward to lift objects, but it is safe and better if you keep objects at a level of height where it is easier for you to lift them, because there is a safe lifting zone in the body. So you may keep things on high raised shelves, but if you have to lift things, there is a correct way of doing it. Since most of us just tend to bend forward and lift things up, that puts a lot of pressure on your back. Here you're supposed to do it in a way where your back is straight and you have a broad base setting, and then you tend to squat down and then lift objects up while maintaining that straight posture in your back. That reduces the pressure on the lower back. Now, like I talked about pregnancy earlier, there are a lot of there's back pain that is associated with pregnancy as well as post LSCS as well as abdominal surgeries. So there are multiple ways of dealing with that. Most of it includes exercise, hot and cold therapy, posture improvement, and physiotherapy. So posture. The correct standing posture is when your head is level, your shoulders are rolled back, your abdomen is pulled in, your hands are by your sides, you don't lock your knee, but you leave it a little bend, and you wear supportive footwear. And there are tons of benefit for having a correct posture. But you have to, and no, I have been asked a lot of times that can I wear this posture correcting brace or straps? But these things usually take away the work that your muscles are supposed to be doing and make them weaker. Only conscious efforts and back strengthening will actually correct your posture. This is for the surgeons. Definitely, this is how one should be operating with the proper table height and proper body posture. While we were on this, I added about how the recent introduction of mobile phones puts so much pressure on your neck as well. And with the increasing head tilt, there is increased pressure on your neck. So, there is no magical solution to this back pain that is not of a serious issue. What happens is you have a back problem and it hurts to move. So you stop moving, which causes weakness, and which causes stiffness, and that causes weakness, and that worsens your problem, and it becomes a cycle. So usually in the OPD, we tell patients that even though your back hurts, right now you know it is because of weak muscles, you push yourself and do that physiotherapy. And this should be incorporated at a young age, mid age, and old age. There's a triangle of fitness, I would say. Like, there is strength and stability training, that is with weights. Then there is flexibility in the form of yoga, and then there is cardio in the form of aerobics. You should focus on strengthening your trunk and core for the back, and as well as your quadriceps, glutes, and your hip flexors, since they all play a very important role in also maintaining your posture and supporting your back. These are certain exercises that are very good for the back, as well as swimming, which is very good for your joints. It's not a very resistance kind of a training. Office stretches for people who have long hours of sitting and have no time to do these exercises. So what is ergonomics? Ergonomics is something where you turn your environment in such a way that it supports your working and your body posture and requirements, in a way where if you have to work on your laptop or your computer, your eye level is at the screen position, your proper chair and desk height, frequent breaks and stretching, workspace organization, so you don't have to reach out every time to get something, supportive seating, and neutral spine alignment. So this here on the left side is a back posture, and on the right you can see how her hand is at the 90-120 with supported on the desk, and how the legs are supposed to be. Sometimes, if you're not, some people also incorporate these standing desks where you can also increase the height of the table. If you don't believe me, this chair is what we use for all specialities in our hospital. But this is the chair of the spine surgeon. And this is the chair of the spine surgeon who does not sit but prefers to stand. So he has modified the desk with a standing table thing. So the summary, there are 1,440 minutes in every single day. You have to schedule at least 30 minutes of them for physical activity. Thank you.
Yeah, thank you, Taarini. Wonderful. And the concluding slide was very apt. I think people owe at least 30 minutes for themselves in the entire day. So any comments from Rushma ma'am or Ram sir?
Very well said, Taarini. I think that was a very comprehensive talk, easily understood by all the listeners. And I think in today's time, she has focused more on physical fitness, exercises, and posture. So, Cash Young, that also she has emphasized, and she just touched upon a topic, and that is how all women as mothers should also look out for their children. So I think when you educate a woman, the also educates the next generation about posture, about how to stand, ergonomics, and things like that. And I think her talk is so good that it should actually be taken to all the schools across Dr. Ram. Lectures like this should be taken to the educational institutions where posture is so important for today's children who are sitting on the desk and studying all the time.
Thank you, ma'am. Yes, ma'am.
Excellent talk, young lady. I am most impressed by the way that you made it appear so very personal and coming from you. That's the way that we appreciate it. So there are a lot of points that you've alluded to, and I'm sure that this can just be the basis of the lecture as planned by Rushma, which should actually be spread all over the country and should be as a patient education program where you're speaking to not necessarily medicos, but to the common person. So I think it's a good talk, and let's work on it. And all the best. Thank you so much. Over
Thank
to Chasanal.
Thank you, sir. And with this wonderful talk from Taarini, the next amazing speaker we have is Sharvari Gunjotikar. She has already completed her primary spine fellowship in Mumbai at Bombay Hospital. Currently, she's joining us from Japan, where she's doing her fellowship in advanced techniques of spine surgery at Okayama Rosai Hospital with Dr. Musato. And over to you, Sharvari. Please share your screen, and we would like to know more from you about more spine health.
Can everyone see my screen?
Yeah, it's visible. Thank you.
Good evening, everyone. I'd like to thank Team Voice and everyone for allowing me this opportunity to be speaking here on the occasion of International Women's Day. So what exactly is scoliosis? It's a three-dimensional deformity of the spine with lateral deviation from the midline with rotation of the vertebrae. And there is a deformity which is seen in the sagittal, frontal, and coronal planes. So there are numerous possible etiologies for scoliosis. However, idiopathic is the most frequently encountered, and particularly the adolescent form is the most commonly seen, with an incidence of 2 to 3% worldwide. If you look closely at the magnitude, at the curve magnitude and the prevalence in different genders, the prevalence of low magnitude curves is similar for both genders. But if you see from this table here, as the curve magnitude increases, there is a striking increase in the prevalence among females, with curves more than 30 degrees having an incidence as high as 10 times more in females compared to males. So as we all know, a careful history and physical examination is what is needed to make the diagnosis of AIS, as it is mostly a diagnosis of exclusion. And every possible effort should be made in order to identify any non-idiopathic curves. And we must also pay attention to the impact this deformity has on the function, cosmesis, and the psychology of the patient and the parent as well. So more often than not, deformity and concerns regarding cosmesis are the most common complaints that are encountered. And the first indication is usually that that something is wrong is there is issue with the clothes fitting right for these patients. Other complaints are generally not that common. When we examine these patients, it is important for us to go through a detailed birth history as well as an antenatal history, and to study the developmental milestones and the family history, particularly if any siblings or family members have had similar deformities. And we must also inquire regarding whether or not the female is, if it is a female patient, whether or not menarche has been achieved, as this period is usually when the curves tend to rapidly progress. So when we examine these patients, we're looking at the general alignment to look for whether the head is tilted or whether it's central, the level of the shoulders, the location of the deformity, whether it's the convexity to the right or left, the prominence is thoracic or lumbar, any asymmetry of the waist, pelvic obliquity, limb length discrepancy, and we must always do a thorough neurological examination in order to make sure that this is a pure idiopathic curve and not any other form of scoliosis. So we must also look for any other signs that may indicate a non-idiopathic scoliosis, such as cafe au lait spots or other pigmented patches, tufts of hair, subcutaneous tumors, joint contractures, etc. So when we evaluate these patients, we look at whole spine standing X-rays in the AP and lateral view, and side bending X-rays and traction view for assessment of flexibility. So when I'm looking at an AP view, we look at the Cobb angle from end vertebra to end vertebra, the coronal balance, that is the alignment of the C7 plumb line in relation to the central sacral vertebral line, the apical vertebral translation, the level of the shoulders, pelvic obliquity, and last but not the least, we look at the sagittal profile as well. And majority of these would have a thoracic hypokyphosis instead of a normal kyphosis. So moving on to the side bending X-rays, we must visualize all the curves in the side bending views, and the right bender is mainly for the thoracic curve, whereas the left bender is for the proximal thoracic and the lumbar curve. So the main aim of these views is to assess the flexibility of the curves, and to determine whether or not a minor curve is a structural curve or a non-structural curve. So a non-structural curve is one that corrects itself to less than 25 degrees on a side bending view. So not all MRIs are not always needed, but in certain situations where there is a rapid progression, or if there is an earlier onset of the deformity, or if there's an abnormal sagittal profile or an atypical curve pattern, MRIs are definitely warranted. Moving on to the treatment guidelines. So the Scoliosis Research Society is a global organization, and they have given us certain guidelines that we follow. According to them, curves less than 20 degrees are to be monitored, and those between 20 to 45 degrees in skeletally immature individuals require bracing. Those more than 50 degrees are ideally candidates for surgery. So whenever we perform any surgery for deformity correction, the main aim is either cosmesis. The main aim is cosmesis, and to achieve cosmesis and balance, and to provide and to bring out a spinal fusion without compromising on too many levels. So the basic questions that arise are which curves do we fuse? And if at all there are two curves, then can we just fuse one? And if at all we do, then how many levels do we fuse, and which others levels? So the earlier classification given by King and Moe was described certain curve patterns, and it aimed to answer these questions. They described 5 patterns of curves, and given the early criteria for what we call selective thoracic fusion. But there were certain problems with this classification system. That one of these was that they did not account for the deformity in the thoracic plane, in the coronal, in the sagittal plane, and they did not include any lumbar curve patterns. So then came the Lenke's classification, which we are all aware of, which included deformity in the sagittal plane as well. And the first step it was the identification of the curve, whether it is a proximal thoracic, main thoracic, or a lumbar curve. And then the curve that is larger is the major curve, and the curve that is smaller is the minor curve. And depending on these, there are 6 broad types and about 42 different subtypes depending on different modifiers and the alignment in the sagittal plane. So then came the concept of selective thoracic fusion, which was given by Lawrence Lenke, which basically means that we fuse in certain feasible curve patterns, we fuse only the thoracic curve with the aim of saving as many lumbar levels as possible. So this concept was given by Lawrence Lenke, and he basically described ratios for the apical vertebral translation and the Cobb's angle between the thoracic and the lumbar curve. And if it was more than 1.2, then we can go ahead and fuse only the thoracic curve. But even with these guidelines, this question still arises where do we start and where do we end? So for that reason, the general guidelines are that if we for the upper instrumented level, we rely on the level of the shoulders to decide the upper instrumented level. If the left shoulder is high, we go to T2. If the right shoulder is high, we go to T4. And if the shoulders are neutral, then we stop at T3. So then where do you stop at the lower level? For that, there have been numerous concepts that have come and gone with the stable zone of Harrington, then came the stable vertebra, and now there's the concept of the last touched vertebra and then stable sagittal vertebra and so on. So we need to take into account the lower level in terms of the AP as well as the lateral view, and choose an appropriate vertebra such that the last touched vertebra in the AP view and in the sagittal view, it is important to stop not to stop at a kyphotic segment. So this is an example of a 15-year-old female with a double curve who met the criteria for selective thoracic fusion, as you can see here. And these are her bending and traction views. And as you can see from the left bender, the lumbar curve was non-structural. So we went in and did a posterior spinal fusion with posterior deformity correction and spinal fusion from T2 to L1. This is another example of 11-year-old female with a left thoracic curve with a preoperative Cobb angle of 106 degrees. So her bending and traction view showed that the curve was not so flexible. So we used additional measures. We used an intraoperative skull femoral traction, and we were able to achieve a good outcome post-operatively. Thank you.
Yeah, so thank you, Sharvari. Yeah, that was a nice talk about adolescent idiopathic scoliosis. And as a pediatric ortho surgeon, we always want to focus on this topic and maybe work on some school screening programs for such adolescent idiopathic scoliosis so that we can pick them early. So we just wait for any questions and comments from the expert panel. And even if we have questions from any audience, maybe Poonam can help us. And so
I think she has handled a very complex topic in a very simple manner, and she has outlined both the classification, the diagnosis, and the treatment in a very simplified manner. So I congratulate you on giving such an excellent talk.
Thank you.
Now that you are in Japan, and you are working there, do you see any difference in the approach to the management of adolescent idiopathic scoliosis as versus what you saw here in India?
Ma'am, actually, I just got here this week, so I've been able to see about 2 cases. So in one of the cases, they were slightly more aggressive compared to what we would do. So they've gone in anteriorly, and but yes, the anterior approach does save a few more levels compared to the posterior approach. So that was a good thing too.
Yeah, so they are more aggressive anteriorly. They are still doing a lot of anterior approach.
Yeah, they are. Yeah, yes.
Yeah, they are. Yeah,
Yes.
because here now we like to do more and more all
More
posterior
Yes,
approach.
yes.
And we think that it is better because then if there's a problem with the implant, then removing the implant
Yes.
is a problem
Yes.
from anterior, you're saying.
Yes.
So, Dr.
Also,
Ram,
it
you would
is,
like.
also it is fairly not a very common approach for a beginner like me. So it's obviously it has a big learning curve as well.
Yeah, that is also because orthopedic surgeons in India do not have a general surgical training in opening the abdomen and the chest. So
Yes,
that is why also we are wary of going anteriorly. It is
yes,
not in our curriculum, and it should be included in that. Dr. Ram would like to comment. I think he's an expert on the topic.
See, first and foremost, that was an excellent presentation as far as identification of the curves, the planning. Let's be very clear that our thinking and decision making is not purely based on Lenki or purely on Kings. We combine King and Lenki most of the time.
Yes, sir.
And a lot of this is more for documentation and research.
Yes, sir.
That's because when we go back, it's easier to go to a Lenki and combine it. So
Yes, sir.
planning is more from the perspective of what best would give you an ideal cosmetic result. I'm using the word cosmetic because we are restricting
Yes, sir.
ourselves to AIS right now. And in
Yes,
AIS,
sir.
we're restricting ourselves mainly to women. Hence,
sir.
there our cosmetic results do matter. But for that one reason, where the cosmesis is the integral part of the surgery, I would agree with most of you that the posterior approach is a step ahead. But if you are looking at correctability and saving
Correctability.
costs,
Yes.
in that case, the anterior approach is
Yes.
fantastic.
Yes. Yes, sir. Yes, sir.
And if you can actually go back a few years and combine where you could do anterior releases by minimally invasive, and which can be done, yes, you need to train yourself, then
Yes, sir.
it would add value to your posterior surgery. And we've
Yes,
done it in the past, while you're even a mini anterior today, or a thoracoscopic or a retroperitoneoscopic anterior releases do add value, make your posterior surgery easier, load the implants less, and can actually get you away with lesser segments fused. So all these things, but as I said, we are now more driven by pure posterior and the devices which can help you correct.
yes,
So
sir.
we are relying more on the correctability of the hardware rather than the true correctability by release. So somewhere in between, and I'm sure that the wheel will come all the way around, and someday we'll again go shorter and be able to achieve the anterior release, maybe from
Yes.
posterior. So all the best. Thank you so much.
Thank you, sir.
Thank you so much, Sharvari, and all the best to you for your further studies and fellowship
Thank
at
you, ma'am.
Japan. Thanks a
Thank you
lot.
so much.
Yeah, so next we have a very versatile speaker who's a dancer and a trekker, along with her interest in spine. So Mansi is currently doing her secondary DNB at at Leelavati Hospital, Mumbai. And Mansi, please share the screen and let's take this webinar ahead.
Thank you, ma'am. Good evening, everyone. I'd like to thank Voice for giving me this opportunity. Can everyone see my screen?
No, not yet. Can you share
Not
it?
yet? Okay, ma'am.
No.
Yeah.
Yeah, I think, yes, now we can see it and you can go full screen. Yeah,
Yes.
super. Yes.
So my topic is lumbar spondylolisthesis, and specifically, I will be speaking about lytic listhesis. So spondylolisthesis is basically the displacement of one vertebra over another. It is derived from the Greek word spondylos and listhesis, which means slippage of vertebra. Um, And spondylolysis is basically the defect in the pars interarticularis, which is the part of the bone between the superior and the inferior articular surfaces of the of one single vertebra. So moving on to this slip is basically, you can see it in plain lateral radiographs, and this degree of the slip can be expressed as a percentage of the anterior displacement of the inferior vertebral plate of the vertebra above. There are various methods to assess this slip, where we come to Myerding's classification and Taylor's grading, where the slip is graded as 1, 2, 3, 4, depending on the percentage of slip. So it could be 0 to 25%, 26 to 50%, 51 to 75, 76 to 99, and grade 5 is like complete or 100% slip of the vertebra. This we will see later on helps with the planning of surgery for this condition. The etiological classification. So, Wills classification divides spondylolisthesis into the various types. So, type 1 is congenital or dysplastic. So, in congenital or dysplastic, usually the L5S1 facet joint is what's dysplastic, and that is what causes the slippage. Type 2, and the most common level being L5S1. Type 2 is what we'll be discussing today, which is ischemic or lytic, which is because of uh, basically a defect in the pars interarticularis, which is also commonly seen at L5S1 levels. Type 3 is a degenerative listhesis, which is commonly seen at L4-5, followed by L5S1, which forms a part of the degenerative spine disease spectrum, and with progressive loading of the posterior elements of the spine, it leads to segmental instability and then results in a listhesis. Type 4 is traumatic, which can result because of acute trauma, because of a facet fracture or displacement or a pars fracture. Type 5 is pathological, seen in metabolic conditions, in tumors and other conditions. And type 6 is iatrogenic in certain surgeries, such as if a wider decompression is done and facet instability can later on lead to a listhesis. So coming to ischemic or lytic listhesis, this is the most common spondylolytic disorder which is seen in the young population among children and young adults. 50% of them only have a spondylolysis alone, which may later on progress to a spondylolisthesis, which is usually seen after the adolescent stage. Also depends upon the degree of the slip, also depends upon the angle of the slip. Males are twice as likely to have a defect in the past, but females are 4 times more likely to have a high-grade slip and are also more likely to progress into a listhesis. There is also a genetic component to this, and it is seen in certain races. And this is particularly associated with vigorous exercise and sports and seen in athletes where a pre-existing past defect is present and then superimposed with, increased activity, and sportsmen such as footballers or particularly swimming, anything that loads the spine more can then later on lead to a listhesis. So basically there's a hereditary dysplasia at the pars interarticularis, which then with the standing posture and the normal lumbar lordosis that we have of 40 to 60 degrees results in a constant downward axial force. This results in repetitive trauma to the pars. And as a result, we have microfractures which then heal incompletely, and there's always this defect. And eventually what we get is a fatigue fracture of the pars interarticularis. Lytic listhesis is further divided into 3 subtypes. So type 2A is an early fatigue fracture that persists because of constant motion. So there's a poor mechanical environment, it is unstable, and that constant micro motion results in like fibrous tissue formation. There's type 2 where the pars is intact but it is elongated. So repeated microfractures have resulted in incomplete healing. So we have an intact but elongated weak pars. And then type C is an acute fracture of the pars which is caused because of trauma. So signs and symptoms, most of the patients who have spondylolysis usually are asymptomatic and do not present, and sometimes this lysis is just an incidental finding. You have patients who do present with symptoms, have dull aching pain in the back, buttocks or thighs, which is usually exacerbated by activity. With an athlete, you'll see that post-activity, this pain start coming up. This usually also starts after adolescence, when the growth spurt hits. Radicular symptoms are not very common unless you do get any hypertrophic callus around the facet joint, because the instability causes facet joint hypertrophy. Or in high-grade slips, there might be nerve root compression, which might then result in paresthesias and radicular symptoms. These patients are at a higher risk for early onset disc degeneration because of segmental instability. Clinically, you might see patients presenting with a waddling gait. They tend to keep their hips and knees in flexion to attain an erect posture. They also, palpation might reproduce the pain at the unstable segment. Paraspinal muscle spasm. So we might get a functional scoliosis or a kyphoscoliosis or a exaggerated lumbosacral kyphosis because of the muscle spasm. A palpable step may be present. Limited flexion of the spine is seen. Like I said earlier, deformity, which could be a functional scoliotic deformity. Investigation. So the first thing, the most basic investigation we start with is an anteroposterior and lateral view X-rays in the standing position. Also do flexion extension views, and oblique X-rays show the classical Scotty dog sign of the fracture in the pars. CT and MRI. CT is helpful in delineating some of the pars defects which may not be seen clearly on X-rays. And MRIs are done in case you have a patient with radicular symptoms, you're planning for surgery. There are signs of nerve root compressions, and the MRI will delineate any nerve root compression. MRI also shows widening of the pars. As mentioned earlier, we have grading, which can be done radiographically, depending on the degree of the slip. The slip angle or the angle of kyphosis, this is measured as the angle between the superior end plate of the vertebra with a line perpendicular to the posterior border of the sacrum. This is a sensitive indicator of the potential instability and the likelihood of progression, and is useful in planning for surgical management. So, treatment for lytic conservatively, patients who are asymptomatic and have an incidental finding of a pars defect can be followed up SOS on a as and when needed basis. Asymptomatic patients who have a low-grade listhesis can be observed with 3 to 6 monthly follow-up X-rays till skeletal maturity. Athletes who belong to the high-risk group may require restriction and protection in case of incidental finding of a pars defect, even though they're asymptomatic. Um, Conservative treatment includes modification of activities for protection of that segment, physiotherapy to strengthen your muscles, strengthen your back, your core, abdominal muscles, immobilization with the help of a brace or orthosis. And early diagnosis in low-grade slips usually have a good prognosis with conservative treatment. Now, failure of conservative treatment or high-grade slips, or patients who then present with pain or radiating symptoms or compressive symptoms might require a surgical intervention. The main goals of operative treatment are to reduce the pain, to prevent progression of the slip, to stabilize the unstable segment, restore the normal posture and gait, address any neurological deficit if present to prevent neurological deficit or prevent progression of the deficit, and in some cases also improve the cosmetic appearance. The surgical modalities that we have available. So there's fusion without instrumentation, which is not commonly done now. 1/3 of the patients tend to go into non-union or pseudoarthrosis. We then have in situ fusion with instrumentation. We can either do a posterolateral fusion or an interbody fusion as well. And then we have fusion with reduction of the listhesis. Reduction of listhesis has higher fusion rates. The correction is better. However, it can also lead to certain complications. So achieving an absolute perfect reduction is not always necessary. And even in situ fusion does relieve most of the symptoms. Some of the review of literature. So again, lumbar interbody fusion versus just a posterolateral fusion. This particular study showed that at the end of 2 years, um, the the outcome was more or less similar. However, this study was only done on grade 1 and 2 slips. So most of the patient base was low grade slips. However, some of the other studies for higher grade slips indicate that interbody fusion has better outcome and is an overall better way of stabilizing the segment because you get a good 360 degrees all round stabilization. So basically, combined surgical approaches have the highest rates of fusion and successful clinical outcomes. Just presenting 2 cases of this. So case 1 was a 48-year-old female. She presented to us with low back pain and right lower limb radiculopathy, which was the new recent onset complaint. She had the back pain for a while. But recently, because of radiculopathy, she also started getting right EHL weakness with a bilateral pars defect. So MRIs were also done, and a T-lift with a posterolateral fusion was done for this patient. And post-operatively, she was fine and there was no neurological issue. We have another case of a 46-year-old female who also presented to us with low back pain since 3.5 years. She had lower limb radiating pain in both the legs, which initially started in the left leg and then moved on to the right leg and worsened in the past 3 months. So again, we have a classical finding of lysis of the pars and a grade 3 slip. And this is the intra-op and post-op imaging, which was also done with a T-lift and a posterolateral fusion. So the key takeaways is this is a hereditary defect of the pars, which basically is seen mainly in adolescents and young population. Certain high-risk groups are people who are athletes or who are very physically active. Spondylolisthesis with no slip or low-grade slips can be conserved. High-grade mobile slips, ideally an interbody fusion with a cage or bone graft is the way to go for a complete arthrodesis and complete stabilization. Thank you.
Yeah, thank you, Manasi. Thank you so much for this lovely comprehensive talk. So we wait for comments from the expert panel.
I think, Mansi, that was an excellent presentation, and it's one of the commonest pathologies that we address, especially when we use TLIF. And today we are using it both minimally as well as open conventionally. And minimally invasive does have an additional advantage that it's quicker, cosmetically acceptable, and return to function is much earlier. However, the amount of bone graft that you get by the minimally invasive, if you're using the intrabody approach, may at times tend to be less. Overseas, there are people who combine BMP with bone graft, but that has its pluses and minuses because RH-BMP2 tends to sort of throw fusion elements where you don't need them, and you can have a lot of perineural irritations thereafter. So it's a difficult thing to weigh and sort of pick up, but this is one surgery which is a very challenging surgery to begin with, but has phenomenal results if well executed. So keep your antennae up. Don't offer surgery till the patient really buys it, because there are many women in our country who roaming around with listhesis for decades together. Leave them alone. Don't jump for it. But when they really have the back pain as well as the leg pain, then offer it and you'll have happy patients. Thank you so much.
Yeah, very well presented, Mansi. It was an excellent
Thank you,
lecture.
ma'am.
I think the most significant takeaway from this lecture is that we are moving away now in this day and time from the shaky period of having posterolateral fusions, doing fusions, not doing fusions, to the more concrete concept of achieving stabilization and alignment of the patient. And I think instrumented fusion in indicated cases with reduction of the listhesis gives very good results where it is indicated. And so I think this has been the most concrete development in the management of spondylolisthesis is getting back the alignment of the spine. Decompression, of course, is the key point if there is radiculopathy, but getting the disc height and getting the reduction. If you can do these two things safely, then you will get a good fusion, whatever, whether you do an anti-fusion, so I think the significant development in listhesis has been the pedicle screw and the reduction and the good fusion and the development and explaining the parameters, lumbar lordosis, pelvic obliquity, pelvic tilt. So just one point from those parameters. Thank you so much.
Thank you, sir, and thank you, ma'am. So now to our last speaker to conclude the webinar, we have Dr. Priyambada Kumar, and she has already completed her primary spine fellowship at Bombay Hospital, and today she's joining us from Singapore. So we have wonderful young spine ladies from all over the world for this webinar today. So she's currently doing her fellowship in minimally invasive surgery and deformity correction at National University Hospital, Singapore. So thank you, Priyambada, for joining us, and please share your screen, and would like to hear from you.
Is my screen visible?
Yes, it's visible. Just make it full screen. Yeah, it's good.
Good evening, everyone, respected teachers. Firstly, thank you, Rujuta ma'am, Chasanal ma'am, Ram sir, Rushama ma'am, and OrthoTV for giving me the opportunity to be a part of this webinar today. So let's start this discussion on spinal osteoporosis by looking at some disturbing statistics. Rate of osteoporosis after 50 years of age is as drastic as close to 52% in women and around 15% in men. Now, 1 in every 3 women and 1 in 5 men have the risk of sustaining an osteoporotic fragility fracture at least once in their lifetime. Despite these disturbing numbers, it is unfortunate to see that this condition is still highly underdiagnosed in our population. Around 96% of the postmenopausal women who are planned for fusion are not really screened for osteoporosis, and those who are actually subsequently screened, 50 to 70% of them turn out to be osteopenic and osteoporotic. Needless to say, undiagnosed osteoporosis has devastating consequences for the patient, for the family, and even for us as their healthcare givers. They suffer from chronic back pain, hampered activities of daily life, poor quality of life, sustained vertebral compression fractures, Kummel's disease. And if they are not optimally screened and treated straight away without addressing the root cause, we inadvertently result into implant-related complications, proximal junctional kyphosis, sagittal imbalance, all of this resulting in dreaded revision surgeries, the combined result of which is an immense health and economic burden for the patient and for the society as a whole. No, not to forget that the risk of mortality increases by around 15% or 15 times in these people as compared to the general population. Time and again, it has been echoed that the entire elderly population, men more than 70, women more than 65, should definitely be screened for spinal osteoporosis. We have literature concretely supporting this, and now we do have guidelines that are very clear about who is the at-risk population, who should be screened regularly. And in spite of all of this, we need to understand that the apparent burden of the condition that we see is actually just the tip of the iceberg, and the true problem is much more than it appears to be. Less than 20% of the potential group actually gets investigated. And most importantly, which is also the center of my discussion today, is that treatment is solely planned, executed, and monitored only on the basis of a DEXA scan. Now, DEXA is a two-dimensional measuring tool. It lacks depth measurement. What we are interested in is a volumetric measurement of the vertebral body trabecular bone density, which is a three-dimensional value, a volumetric measurement. So DEXA does not seem to be an apt measuring tool for precise measuring of the trabecular bone density in the vertebral body. As you can see, this lateral and axial films, the abdominal aorta of the patient appears to be near about completely calcified. Now, DEXA scan in such a patient is obviously going to result in confounding results because it also includes the calcification of the abdominal aorta. Now, 40% of the population in India today has some or the other extent of abdominal aortic calcification. This is another X-ray where you see the lateral and AP images. Any orthopedic surgeon, when they are looking at the lateral X-ray, they would agree that the patient seems to be osteopenic. But when you see the AP X-ray of the same patient, because of superimposition of the sclerotic, arthritic facets, laminae, the AP picture does not seem to be as bad as the lateral picture. This is how DEXA can be deceiving. The rib and iliac crests can overlap in the lateral films. Fat overlaps in AP as well as lateral views. DEXA is also affected by patient positioning, especially in case of obese patients. Vertebral trabecular bone takes the spotlight of discussion when we are talking about spinal osteoporosis, and it is imperative to get a tool that precisely measures the trabecular bone mineral density in the vertebral body. Not to forget the importance of trabecular bone when we talk about screw purchase during our surgery, when we talk about the strength of the mechanical construct when we are doing multi-level fixations or even fusion surgeries. And also it does influence the spinal fusion post-surgery. But it is sad to admit that lumbar DEXA does not represent a precise microarchitecture of the trabecular bone. This shifted the interest towards Hounsfield units for assessing the bone mineral density, and it was found that there's a good correlation between HU scores and bone health and compressive strength. Also, a higher HU score was seen to be positively impacting a higher success rate in spinal fusion post-lumbar surgeries. This further deviated the interest towards quantitative CT, that is QCT, which is a 3D volumetric measure of the bone mineral density of exclusively the trabecular bone in the vertebral body, which is the most important part that we're interested in. It converts attenuations measured in Hounsfield units to bone mineral density through a special phantom software. And currently, a bone mineral density of less than 80 mg per centimeter cube given by QCT is considered to be osteoporosis. This paper published in the Spine Journal in 2021 is where the authors argued that QCT should be considered gold standard for treatment, initiation, and monitoring of spinal osteoporosis. 718 postmenopausal women were screened both with QCT and DEXA, and it was seen that the mean and mode values of the T-score given by the QCT test was much higher as compared to the DEXA scan. As you can see, this DEXA report of a patient where the average DEXA score, the T-score was minus 0.7, the QCT of the same patient at same point of time gave a T-score of minus 3.32. That is the level of disparity between the two tests that we are talking about. But then again comes the rightful concern about the radiation exposure that the patient will be undergoing if we screen them with QCT. But now literature does have enough evidence to suggest that a well done QCT or a low dose QCT gives rise to dosage which is comparable to an epilateral spine X-ray, which is a little more than the epilateral X-rays, but is far less than the CT spine that we do. So it lies somewhere between the spectrum. QCT overall is a precise volumetric measure of the trabecular bone, which is the most important, which is the person of interest when we are talking about spinal osteoporosis, and is not affected by a bony or fat overlap. However, it does come at the cost of radiation exposure as well as higher costs as compared to DEXA. But then again, for the high risk population that we identify, I think in the long run, it is a relatively smaller cost to pay. To summarize, planning the treatment solely on the basis of DEXA can lead to gross underdiagnosis as well as undertreatment. DEXA is definitely an effective screening tool, but it is time to shift the paradigm towards QCT for definitive treatment planning and therapeutic monitoring. So it's my proposal today that baseline QCT testing should be done for all elderly patients who have been planned for spine instrumentation surgeries, to start anti-osteoporotic therapy only after quantifying the osteoporosis with QCT. And lastly, QCT should be used for therapeutic monitoring once the anti-osteoporotic therapy has been started. Thank you.
Great. So thank you, Priyambada. Great. And I would also like to know Ram sir and Rushma ma'am's opinion on the screening for osteoporosis and what should be the ideal guidelines or treatment for all the general women population out there. So,
Rushma, would you like to go first?
I think so. You are there. Okay, ma'am.
Epidemic. Osteoporosis has reached epidemic proportions in our country. I think it is also to do with poor lifestyle, obesity, increasing incidence of diabetes, sedentary lifestyle. And so, since women are already more predisposed, I think we are heading towards a catastrophe. And this is across all socioeconomic strata. It is not just in the higher socioeconomic strata. So the women at the lower end of the socioeconomic strata have a different set of problems that predisposes them to osteoporosis, which includes poor nutrition, whereas the more affluent have a sedentary lifestyle and other lifestyle diseases that adds to it. So for screening, I think all postmenopausal women should be screened every 3 years, and what we regularly do is a DEXA scan. Priyambada has pointed out, but I think that the amount of radiation from the QCT may not make it universally acceptable. And so a BMD screening once in 3 years is absolutely essential. I think osteoporosis treatment should be initiated at the earliest in every postmenopausal woman who has been diagnosed with a BMD of less than minus 2.5. So that is what we are doing nowadays. And in our hospital, since the railway population can afford it at no cost to their own pocket, so we do regular screening of postmenopausal women, and osteoporosis treatment is available for free. For those who have rheumatoid arthritis or some other diseases, we give denosumab and teriparatide also if it is less than minus 3.5. So this is how we are treating osteoporosis at present. Dr. Ram, if you have
Yeah.
anything to add.
Thank you very much. That was an excellent presentation, Priyambada. First and foremost, I appreciate the fact that the awareness has increased and we need to still spread it further. What you mentioned in your presentation was that all women above 60 or 65 and men above 70. I would actually take a cue from what Rushma has said, and I do it as a routine. I do a DEXA for all women who are postmenopausal, because in our country, if you realize, women menopausing naturally even at 45, and a lot of them do undergo surgical menopause even earlier. So that's one thing that you have to look at. And please also remember that most women who are undergoing elective spinal instrumentation are between 45 and 60. And if you're going to go by screening only above 60, you may have a large number of outliers. So I tend to do my screening preoperatively for all patients. I also very strictly adhere to building up the bone stock preoperatively if I have an elective surgery. Let's say I have a non-neurological patient where I have pain and even early non-disabling neurology. I would put them on 3 to 6 months of aggressive anti-osteoporotic therapy, and if it's really bad, including teriparatide, build it up, continue the teriparatide post-op. So I would operate in that window between 3 to 6 months after initiating teriparatide. Having said that, I would continue 2 years of therapy in them to protect my surgery, and so would the patient be interested in doing the same. The other thing which I also tend to do is the severely osteoporotic, minus 3.5, which deserves surgery or merits surgery. Let's say that there is an osteoporotic fracture which needs surgery and there's now a neurology creeping in. I would even combine denosumab and teriparatide both in the same patient. I would use the best available implants, including fenestrated screws or cement augmented screws, do a long structured sort of reconstruction, even protect my implants with a brace. I do not shy away from protecting my implants with a brace in the osteoporotic spine, because please remember, it's not the fracture of the vertebrae around the screwed vertebra, but one above and below, which tends to bother us more. So it's like a stress riser, which the implant is there. Having said all this, diabetes and smoking are two things which are rampant in our country, and they are actually making life more miserable. And my cutoff today is that if I have a smoker or a diabetic or a Parkinsonism patient, my intent to treat begins at -2 of DEXA and not -2.5. So I sort of push the bar a little bit in this direction. As regards QCT, if we are limiting ourselves to just the spinal study, I agree with you that the QCT will be more specific. However, when we are screening three areas, which is the spine, the hips, and the forearm or the wrist, and looking at the lowest score, I may have a normal looking spine, but if I have a poor DEXA in the hip or in the forearm, I would go with the lowest score and look with that as my intent to treat and start my therapy. I have a much larger number of patients available for screening. Because if I look at even the city of Mumbai, I probably will have 5 QCTs and 500 DEXAs in our city. So if a urban city like Mumbai has this sort of a disproportion, all over the country, if I look at QCT, I may not have more than 100 QCTs in India, but we'll surely have maybe 50 to 100 times the number of DEXAs. I do agree that there is a disparity even between the lunar and the two types of DEXAs. We are not going into that discussion today. But the very fact that non-availability of QCT is going to be a deterrent. So at least do a DEXA. And where DEXA is not available, then use the Indian FRAX. The Indian FRAX is available. Although the Indian FRAX was done on Malaysian-based Indians or Singapore-based Indians, people living in that part of the world. But today, it is similar to the Indian population. there is an true Indian fracs also coming up and to be sort of done with very soon. So we can use the fracs not just for diagnosis, but also planning our therapy. Medicines are available in our country. I mean, I know not everybody gets the free ships as the railways offer, but the other patients also are getting the drugs at a reasonable cost today as compared to where we were earlier. And I tend to use all the four variants. I mean, I'm using everything from a bisphosphonate to a teriparatide to a denosumab. And in the bisphosphonates also, I use both, that is the injectable and the oral. So I have all these four options available depending on the need of the patient. So I am happy doing this. And yes, osteoporosis is something that you have to be aware of. And I know you women will outlive us men, so be careful.
So just a quick question to both of you, Ram and Rushma. What is your opinion on all the fortified calcium and fortified foods which are being kind of marketed as anti-osteoporosis?
Well, I'll just take a brief shot. I would be very happy if the government fortifies with calcium and vitamin D everything from milk to salt.
Yeah.
It would actually add value to our country. And I mean, it's something which if they do it, they'll be doing huge amount of service to society. But to buy these fortified goods, I really don't know, because actually fortifying with calcium and vitamin D is no real expense if you're doing it at a national level. So
Yeah.
it's worth doing that. But I'm not too sure about these fortified and magnesium with D3 and calcium with that. I mean, it's interesting. It's good.
I totally agree with you, Ram, and I think that as IOA president, maybe you should put forward a statement to the government. And tell the IMA that instead of doing all these ads, they should maybe put it forward to the government that they should fortify,
Yeah.
the foods with
Yeah.
calcium, vitamin D. I think the IOA could come out with a statement
Yeah,
on this.
if salt could be iodized many years back,
I
I mean, there's
agree.
no reason why we can't do this today. Absolutely.
Absolutely. Absolutely.
I think we should begin with the railways.
Yeah, that's a captive population we'll have and a sure short thing that will happen, I suppose. So,
Yeah.
just, I think, time
Yeah,
for
so
any audience questions.
everything,
We can take
yeah,
them.
and no, nothing as such, ma'am. So maybe if over the time we get any. So maybe we could, now that we have finished well in time, all the girls have presented very good in time, crisp and nice presentations, lovely take home messages, educational videos, which can be shared with the general population on this eve of International Women's Day. So thank you all the speakers, and I request Rujita ma'am to extend the vote of thanks.
So I think thank you is going to be a really small word today because probably we've really just begun a journey. I remember many years back, Ram and I had this conversation when he was probably not even thinking of being IOA president and I was not even thinking of being BOS secretary. That now that there are women in ortho, maybe y'all should really seriously take up something like a scoliosis school health program, and on grounds of being more the empathetic or the fairer sex or the more caring sex, we should look into geriatric care as well. And I think both of his words were pretty much futuristic right then itself, because this is what is going to be the need of the hour. As we are seeing more longevity, we are going to see more and more of fragility problems. And if we really can pick up scoliosis really early through school health clinics, that's going to be a huge turnaround in the way deformities in the girl population come to us, And it is totally heartwarming to see so many of you bright minds and such experienced and wise mentors that you have in Rushma and Ram and many others. So I would really urge these girls to make it some sort of a voice mission and a personal mission to keep on working to raise awareness for these at least two problems at the two ends, at the pediatric and the geriatric spectrum, and the rest will, I think, all fall into place. And of course, for Ortho TV, one must give them a big thank you for always having our back. Whatever program we initiate, they're always there to support. And Chas for always stringing things to be better. And they say that there's a Mr. Reliable in everybody's life. I think in mine, it's a Miss Reliable, and that is Chasanal. And all of you have a great future ahead. And all the best. And let's rock Women's Day tomorrow. Bye-bye. Thank you.
Happy Women's Day to all. Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Okay.
Once we are off the live recording,
We are
then
still live. And Poonam, can you stop the live recording? Oh, Poonam is already celebrating Women's Day.
all right. Very